Welcome to the deep dive. Today we're tackling pubic symphysis dysfunction, SPD.
That's right, SPD.
If you're, revising for your MSRA and need the key facts, especially how it links to pregnancy, this is for you.
Absolutely.
So SPD is basically pain and instability in that joint right at the front of the pelvis.
Exactly, where the two halves meet.
And it's surprisingly common, particularly during pregnancy, isn't it? It can really affect day-to-day life.
It really can. So definition-wise, it's that pain and instability, specifically in the pubic symphysis joint.
Okay.
And the big connection with pregnancy is hormonal. There's this hormone, relaxin,
Ah, yes, relaxation.
which increases, making ligaments looser. This leads to the instability. Key things to look for are pain right over the pubic bone, maybe spreading into the groin or thighs,
Right.
and sometimes that characteristic sort of waddling gait.
Got it. Okay, let's dig into the causes, the etiology.
Well, the main one, as we said, is those hormonal changes during pregnancy. Relaxin is the key player making ligaments lax.
Leading to instability.
Exactly.
Yeah.
But it's not just pregnancy. You can also see it after trauma, like a fall or accident affecting the pelvis,
Makes sense.
or even repetitive strain, maybe from, certain sports or activities. And sometimes pelvic inflammatory conditions can be involved too.
Okay, so a few different triggers, like hormones, hits, and hubbub. Is that a way to remember it?
Yeah, something like that works. Hormones, trauma, strain, inflammation covers the main areas.
And who's most at risk then?
Well, pregnancy is definitely number one, big risk factor.
Too surprised there.
And if you've had SPD in a previous pregnancy, you're unfortunately more likely to get it again.
Right.
Also, multiple pregnancies, so carrying twins or more, or having had several babies.
That adds up.
And things like delivery complications, maybe a very fast labor or needing instruments. Increased weight also puts more stress on the pelvis. Hormonal factors generally, and just anything placing repeated stress on that area.
So lots of P's, pregnancy, previous SPD, plural pregnancies, pressure from weight.
Exactly. And plus, hormones. That's a good way to think about it.
Okay, so we know what it is, who gets it,
Mhm.
but what's actually going on in the body? The pathophysiology.
Fundamentally, it's about increased laxity, like looseness, or sometimes even a small separation at that pubic symphysis joint.
Okay.
Relaxin, that hormone we keep mentioning, is really central here, making the ligaments more stretchy.
Right, more elastic.
Yeah. And this extra movement combined with altered biomechanics, how the pelvis moves and bears weight, especially changing during pregnancy, that leads to the pain and feeling of instability.
Like the foundations are a bit wobbly.
That's a good analogy, yes. A slightly unstable base.
So if someone presents with these kinds of symptoms, what else needs to be on the radar? The differential diagnosis.
Crucial for revision. You need to think broadly. Could it be osteoarthritis in the hip or spine?
Okay.
Or general pelvic girdle pain that isn't specifically SPD? Maybe a hip issue like a labral tear?
Hernias too sometimes.
Yes. Inguinal or femoral hernias can cause groin pain. Even a urinary tract infection, a UTI, can sometimes present with lower abdominal or pelvic discomfort. And don't forget other musculoskeletal injuries, muscle strains, stress fractures, things like that around the pelvis. You have to rule these out. Maybe think joints, groin, and other pains.
Good. Framework. How common are we talking here? Epidemiology.
In the UK, the estimates hover around 1 in 300 pregnancies, so fairly significant.
Wow, okay.
It's much, much less common in people who aren't pregnant, but it definitely can still happen. Pregnancy is the main association, though.
So clinically, how does it typically present? What would a patient actually tell you?
The classic story is pain directly over the pubic bone, right at the front.
Very specific.
Yes, and that pain often radiates maybe to the lower abdomen, into the groin, sometimes down the inner thighs or into the hips.
And activities.
Big trigger. Anything involving weight bearing usually makes it worse. Walking, climbing stairs, getting in and out of a car, even just turning over in bed can be really painful. They might also mention difficulty parting their legs, like getting dressed or standing on one leg. That single leg stance test can be provocative. Think pain, radiation, aggravation with movement, limited mobility.
Okay. And how do we confirm the diagnosis? Investigations.
It's primarily a clinical diagnosis.
So based on what they tell you and the exam.
Exactly. Taking a good history is key, listening to those symptoms we just discussed. Then the physical examination, looking for tenderness over the pubic symphysis, maybe checking for instability with specific tests.
Like the single leg stance.
Yes, or Patrick's test, things like that. Imaging like x-rays or ultrasound.
Yeah.
Well, they aren't usually needed for the diagnosis of SPD itself.
Okay. Okay.
But they can be really useful sometimes to rule out those other things in the differential diagnosis if the picture isn't completely clear.
Got it. So mainly clinical. Now, management, what can be done?
The main goals are really threefold: relieve the pain, improve their function in daily life, and provide support to the joint.
Makes sense. How do we achieve that?
Physiotherapy is usually the cornerstone.
Physio, right.
Yeah, focusing on exercises to strengthen the pelvic floor, the core muscles, the glutes, all to help stabilize the pelvis. They also use techniques for pain relief.
What about supports?
Pelvic support belts or braces can be incredibly helpful for some people. They sort of physically hold the joint more stable.
Like an external support.
Precisely. And then for pain itself, simple analgesia, like paracetamol, is often the first step. Sometimes low-dose opioids might be considered if the pain is severe, but always carefully, especially in pregnancy.
Of course.
And if things are really bad or not improving, then referral to a specialist, maybe an obstetrician or orthopedic surgeon, might be needed. So think physio, support, pain relief.
Good summary. And the outlook. What's the prognosis usually like?
Generally, it's good. For most women, the symptoms significantly improve or completely resolve after they give birth.
As the hormones settle down.
Exactly, as relaxin levels drop and the ligaments regain their usual tension. With appropriate management during pregnancy, long-term problems are usually avoided.
That's reassuring.
It is. But it's worth knowing that for some, symptoms can linger postpartum, or they might recur in future pregnancies.
Right, that risk factor again. Are there any serious complications to worry about?
Thankfully, major complications are rare,
Oh, okay.
but, some individuals might unfortunately develop chronic pain that persists long after delivery, leading to ongoing limited mobility.
Which impacts quality of life.
Definitely. And severe, poorly managed SPD could potentially increase the risk of other issues like pelvic floor dysfunction or even contribute to postnatal depression just from the sheer difficulty and pain involved in daily life.
Understandable. Okay, so let's quickly recap this deep dive on SPD. We've got pelvic pain and instability, often linked to hormones, especially relaxin during pregnancy.
Yep, that's the core.
Key signs are that pubic pain, often radiating, and made worse by movement or weight bearing. Diagnosis is mainly clinical.
History and examination are key.
And management focuses on physio for stability, support belts, and pain relief. Prognosis is generally good, usually resolving after delivery.
But watch out for persistence or recurrence and those rarer complications.
Right. So a final thought then. Thinking about how central relaxin and biomechanics are, how might that understanding influence how we manage joint instability even outside of pregnancy?
That's a great question. It really highlights the interplay between hormones and musculoskeletal stability, which could potentially inform treatments for other conditions involving ligament laxity, couldn't it?
Definitely food for thought. Well, that's all we have time for on SPD. For more MSRA revision resources, remember to check out pastthemsra.com.
And also, freemsra.com for loads of free questions and guides.
Thanks for joining us for this deep dive.